The macula and the fovea. The macula appears yellowish red in color due to high content of xanthophyll pigment. The center of the macula lies 2 disc diameters from the center of the disc. The macula is 3 disc diameters. The fovea is a dark red area in the center of the macula. It contains only cones. The fovea is approximately 1 disc in size. The retinal vessels include the central retinal artery and central retinal vein. The central retinal artery divides into upper and lower branches, each divided into nasal and temporal branches. The center of the fovea is avascular, which is called the foveal avascular zone, and receives its nutrition from the choroid. The central retinal veins accompany the artery. The retina proper appears pink in color, but it is transparent. The pink color is the color of the blood supply in the underlying choroid. Retinopaths. Definition: it is a bilateral affection of the retina due to a systemic disease. The most famous one is diabetic retinopathy. Diabetic retinopathy is a microangiopathy, which means that it affects mainly the small blood vessels. It affects the retinal capillaries, arterioles, and venules. The risk factors for developing diabetic retinopathy include duration of diabetes. The longer the duration, the more likely to develop retinopathy. Metabolic control. Good metabolic control does not prevent retinopathy, but it merely delays its onset. Miscellaneous risk factors include pregnancy, hypertension, renal disease, smoking, and anemia, and all of them worsen retinopathy. Pathogenesis of diabetic retinopathy include ischemia and leakage from the blood vessels. The clinical types of diabetic retinopathy include 3 stages. First is background diabetic retinopathy. The main findings in this stage are microaneurysms, hemorrhages deep in the form of dots, hard exudate, retinal edema. When close to the macular area, vision is seriously affected. The second stage is we call pre-proliferative diabetic retinopathy. It is due to retinal ischemia and shows the following: venous changes in the form of beading and looping, blood hemorrhages, cotton wall spots due to capillary occlusion, intraretinal microvascular abnormalities, and extensive areas of ischemia which may be detected by fluorescein angiography. Third stage is the proliferative diabetic retinopathy, in which we can see new vessels that may develop on the optic disc, so-called new vessels at the disc, or elsewhere, so they are called new vessels elsewhere. They are unhealthy, fragile, and liable to leakage and hemorrhage. Hemorrhages, which may be retinal, pre-retinal, or vitreous hemorrhage. Later, fibrosis occur around the new vessels, exerting traction on the retina, resulting in tractional retinal detachment. Diabetic maculopathy. It is involvement of the macula by edema and or hard exudate, and is the most common cause of visual impairment in diabetic patients. The clinical presentation of diabetic macular edema may be in the form of focal edema, diffuse or cystoid edema, ischemic edema, and mixed type. Complications of diabetic retinopathy include persistent vitreous hemorrhage, retinal detachment, opaque membranes, neovascular glaucoma due to rebusus iridis. These occur where laser treatment was not implemented and in the early stages of the disease. These are vision-threatening complications. How to manage diabetic retinopathy? First, control of blood sugar. Second, follow-up of diabetic patients at regular examination. If the patient is without retinopathy, it is yearly non-proliferative diabetic retinopathy every 6 months. Fluorescein angiography and optical coherence tomography is done to detect leaking area and ischemic changes. Focal argon laser photocoagulation in cases with clinically significant macular edema, while pan-retinal photocoagulation using argon or diode laser in patients developing new vessels. Intravitreal injections of triamcinolone or antivascular endothelial growth factors. Vitrectomy in severe cases where the patient develops recurrent vitreous hemorrhage, tractional retinal detachment, macular epiretinal membrane, and rebusus iridis associated with vitreous hemorrhage is an indication for vitrectomy, and intraoperative pan-retinal photocoagulation to prevent neovascular glaucoma should be applied. How we can treat macular edema? Laser treatment with focal laser therapy can be applied. Intravitreal injection is needed when the edema is centrally located. We can inject triamcinolone acetonide, which is a steroid, or antivascular endothelial growth factors. Second, retinopathy is the hypertensive retinopathy. Retinal arterioles respond to hypertension by narrowing. This is the first physiologic response of the retinal blood vessels or any blood vessel in the body. So the fundus picture will be arteriolar narrowing, which may be localized or generalized. After a persistent elevation of blood pressure, there may be leakage due to abnormal permeability of the vessel wall, leading to appearance of flame-shaped hemorrhages, retinal edema, and heart exudate. This edema develops in malignant cases, which means that the blood pressure is persistently very highly elevated. Arteriosclerosis causes thickening of the vessel wall, leading to appearance of what we call arteriovenous crossing changes. Grading. In grade 1, we find mild generalized arteriolar attenuation, especially the branches. In grade 2, more severe arteriolar constriction. In grade 3, copper wiring of the arterioles as well as silver wiring of the arterioles associated with flame-shaped hemorrhages, cotton wool spots, and hard exudates. In grade 4, we find disc edema. Other ocular complications of hypertension include retinal vein occlusion, retinal artery occlusion, ischemic optic neuropathy, ocular motor nerve palsy. Uncontrolled hypertension may adverse the effect of diabetic retinopathy, which means that it could worsen the retinopathy state. What about retinopathy due to renal failure? Vessels will show changes of hypertensive retinopathy, but aggressively. Due to toxemia of pregnancy, we can find a retinopathy which is by definition a bilateral retinal affection secondary to hypertension and toxemia of pregnancy. The pathology includes it affects female after the 20th week of pregnancy. Retinal arterioles show marked vasoconstriction leading to ischemia. Treatment is by termination of pregnancy if the patient develops exudative retinal detachment characterized by rapid bilateral onset in the absence of retinal breaks. The retinopathy resolves after termination of pregnancy and the prognosis of vision is good. Second topic in our lecture is retinitis pigmentosa. Retinitis pigmentosa is a retinal degeneration due to hereditary disorders characterized by progressive loss of photoreceptors. Etiology: the definitive cause is not known, but it is a hereditary, mostly disease. The clinical picture is gradual progressive loss of vision, night blindness, which means defective dark adaptation, concentric contraction of the peripheral field. Ophthalmoscopy include arteriolar attenuation, spider-like pigmentation at the equator or the periphery of the retina, and later consecutive optic atrophy. Electrophysiologic test: electroretinogram is markedly diminished. The prognosis is usually bad. Age-related macular degeneration is a visual loss associated with atrophy of the retinal pigment epithelium in patients above the age of 50 years. Fourth topic is optic atrophy, which means the degeneration of the axons of the optic nerve fiber. Types: we have 4 types: primary, secondary, consecutive, and glaucomatous optic atrophy. The primary optic atrophy is caused by lesion primarily affecting the optic nerve behind the eyeball. So the causes include a central nervous system disease as tabes dorsalis disseminated sclerosis, severe blood loss as in severe hemorrhage, cardiac arrest, and cardiac surgery, toxic as tobacco or cigarette smoking, pressure on the optic nerve by tumors, aneurysms, space occupying lesion. The ophthalmoscopic picture include the color. It becomes milky white. The edges are well defined. The cup is not filled. The lamina cribrosa can be seen. The retinal blood vessels are normal. The surrounding retina is normal. In secondary optic atrophy, the pathology is at the optic disc. It is optic atrophy following an accident at the optic disc as papilledema or papillitis. Causes papilledema or papillitis. Ophthalmoscopic picture. The color, it becomes grayish white. The edges are ill-defined. The cup is filled. The lamina is not seen. The retinal blood vessels are sheathed. And the surrounding retina shows pigmentary changes. In consecutive optic atrophy, which is yellow optic atrophy, the optic atrophy is due to massive chorioretinal disease. Causes include central retinal artery occlusion, retinitis pigmentosa, massive chorioretinal degeneration, and very high myopia. Ophthalmoscopic picture. The color of the disc is waxy yellow. The edges are ill-defined. The cup is filled. The lamina cribrosa is not seen, and the surrounding retina shows evidence of consecutive disease. Blood vessels are markedly attenuated.